management.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. بسم الله والصلاة والسلام على رسول الله. شكرا دكتور عماد. Take the hard part يعني from the whole guidelines and presented nicely. جزاك الله خيرا. We'll go directly in the topic and my talk will be about the difficult airway guidelines. It's the 2022 American Society of Anesthesia practice guidelines for the management of difficult airway. These guidelines came to replace the practice guidelines that's published in 2013. The one before it was 2002. So every 10 years, they are reviewing the guidelines for difficult airway management. It differs from the previous guidelines. Can you see this? It differs from the previous guidelines that this new guidelines is by international task force. The previous one was by only the American Society of Anesthesiology. Now 10 participating organizations added to the American Society of Anesthesia to publish these guidelines. It contains development for the difficult airway management strategy, including consideration for awake airway management. It's either laser or pointer. ما بتمشي للصفحة دكتور. خلاص it's okay. خلاص it's okay. Running. It includes updates about equipment for standard and advanced difficult airway management. It emphasizes on the recommending supplemental oxygen administration during extubation process. It emphasizes awareness of the passage of time and limiting the number of attempts. How many attempts? Not exactly mentioned, but they repeat these phrase, limit the attempt during difficult airway management. More recommendation for extubation of the difficult airway. To define the difficult airway, we start with difficult face mask ventilation. It's not possible to provide adequate ventilation because of one or more of the following problems: inadequate mask seal, or there is a gas leak, or there is resistance to in or outflow. Difficult laryngoscopy defined as not possible to visualize any portion of the vocal cords after multiple attempts at laryngoscopy. Also, the number of attempts here not specified. Difficult supraglottic airway ventilation defined as difficulty in placement or placement requiring multiple attempts, inadequate seal, excessive gas leak, or excessive resistance to in or outflow. Difficult or failed tracheal intubation defined as requiring multiple attempts to or fails after multiple attempts. Difficult or failed tracheal extubation, the loss of the airway patency and adequate ventilation after removal of the tracheal tube or supraglottic airway from the patient with a known or suspected difficult airway. Difficult or failed invasive airway, defined as anatomic feature reducing or preventing the likelihood of successful placing an airway into the trachea through the front of the neck. For evaluation of the airway, it includes, need to be included this information, demographic and personal characteristic, age, sex, body mass index. This is all the routine what we are doing every day, but it's mentioned specifically in these guidelines. Clinical characteristics include history of difficult intubation, distorted airway, anatomy or snoring, obstructive sleep apnea, diabetes. Finding for diagnostic tests, chest X-ray or CT, Measurement of the facial and jaw features include mouth opening, the ability to prognose the teeth, head and neck mobility, prominent upper incisors, presence of beard, and the upper lip bite test. Anatomical measures that we can do to evaluate the airway included Malambati score, thyromental distance, sternomental distance, interincisor distance, neck circumference, ratio of the neck circumference to the thyromental distance, ratio of the height to the thyromental distance, hyomental distance, and hyomental distance ratio. Advanced, we could do it through measurement obtained from ultrasound, included skin to hyoid distance, tongue volume, and distance from skin to the epiglottis. These pictures to explain what we are talking about. This is the Malambati score, ranging from class 1 to class 4, and the difficulty increasing till class 4. 332 rule, mouth opening, three finger, they consider it 6 centimeter. Hyomental distance more than 6, and thyrohyoid distance more than 2. This is indicating possible intubation. And here we see the hyomental distance more than 6.5, normal or easy intubation, 6 to 6.5. Laryngoscopy intubation difficult, but may be possible. Less than 6, laryngoscopy intubation impossible. Summary for all of these measures, which one should we depend on? No single characteristic was identified as consistently being more predictive than another, and multivariant measures are recommended. Recommendations for the evaluation of the airway, they said that we need, before the initiation of the airway management, we should ensure that an airway risk assessment be performed by the person who is responsible for the airway management. Trust your colleague, but double check and do the exam yourself. Conduct an airway physical examination. This is what we said before, the measures that we need to do. Assess multiple airway features to determine patient's potential for a difficult airway or aspiration. Guidelines for the preparation for difficult airway management to include availability of the equipment, information about the patient, pre-oxygenation, positioning, sedative, supplemental oxygen, and monitoring. It's our routine practice that we are doing, but it's written specifically. Preparation for difficult airway management. This is the items that need to be available in the intubating area. It's the equipment that we need, and from for simple airway management to advanced. And this is the suggested content of the difficult airway trolley. We'll talk now about anticipated difficult airway management. We are, before we start with, we know or we suspect that there is a difficulty in the airway management. How should we deal with this scenario? You should have a clear strategy with alternative plan and backup, and perform awake intubation if patient is suspected to be difficult intubation, and have one of the features that will be mentioned as next: difficult ventilation, either face mask or supraglottic airway, increased risk of aspiration, or incapable of tolerating a brief apneic episode, or difficulty with emergency invasive airway rescue is anticipated. And we should provide and test mask ventilation between attempts. We should be the stress guide us. We should try to manage the situation and apply the algorithm and test every time for possible ventilation. Maybe after deepening of the sedation, adding muscle relaxant, something improved in the ventilation. This is the points that I mentioned before, and here the agreement between the committee members, ranging from strongly agree to strongly disagree. Regarding guidelines for unanticipated and emergency difficult airway management. We should determine the benefit of waking the patient up and restoring spontaneous breathing. انسحاب يعني بأقل الأضرار. Determine the benefit of non-invasive versus invasive approach to the airway management. If difficulty is encountered with individual technique, we should go for combination technique. Provide test mask ventilation between attempts, as I mentioned before, for anticipated difficult airway. It's the same for unanticipated. Between intubation trial, we should try and again for giving mask ventilation. If invasive procedure planned to be performed, the most trained person whenever feasible, limits the number of attempts. How many attempts? Not mentioned. And we should be aware of time passage. Again, the table with the level of agreement between the committee regarding the items that I just mentioned. Confirmation of the tracheal intubation. We should confirm the tracheal intubation using capnography. And if we are uncertain about the location of the tracheal tube, we should determine either to remove it and attempt ventilation or use additional technique to confirm the positioning of the tracheal tube. Guidelines for recommendation for extubation of the difficult airway. Ensure that the skilled individual is present. We should select an appropriate time and location. And for extubation, whenever possible, even if we need to extubate the patient in OR with surgical team standby, it's one of the options. Assess the relative clinical benefit and feasibility of the short-term use of an airway exchange catheter, Cook catheter, and or supraglottic airway that can serve as a guide for expected re-intubation. Have anybody used this way in the practice? Using Cook catheter to extubate the patient? By raising the hand? And it's just maybe, and it's an option. You should judge the benefit and risk. If the patient gag reflex is patent and the possibility of aspiration, you should take decision depending on the patient's condition. But it's a solution to avoid loss of airway after extubating the patient. Evaluate the risk and benefit of elective surgical tracheostomy before. If you have doubt, you can proceed directly for elective surgical tracheostomy. صوت مسموع. Algorithms and infographics for the pre-airway management decision-making tools. If you have suspected difficult airway and laryngoscopy or intubation is suspected, and the patient have suspected difficulty in ventilation with face mask, then we can proceed to awake airway management. Who's the patient who have suspected difficult face mask ventilation? Older age, male sex, obesity, edentulous, facial hair, Bellambati 3 or 4, inability to protrude the mandible, short theromental distance, snoring, abnormal neck anatomy. Proceed. If you have suspected difficult airway or intubation, and we have significant increased risk of aspiration, then we can proceed to awake airway management. Who's the patient have significant increased risk of aspiration? If the patient have full stomach, non-fasted, emergency surgery, pregnancy, 12 to 20 weeks, symptomatic gastroesophageal reflux, diabetic, for gastroparesis, hiatal hernia, and other reasons. If you have difficult airway, suspected difficult airway, and increased risk of rapid desaturation, the patient cannot tolerate the apnea time, then we can proceed to awake airway management. We see here how fast the desaturation happen after administration of muscle relaxant. The counts here in minutes, and we see the obese patient is average weight 127, desatting as fast, child, moderately ill patients, normal adult patients up to 10 minutes. If we intubation attempt after induction of anesthesia, we intubated the patient and we tried to intubate and we failed. Also, we should limit the attempt and follow this algorithm. Can we ventilate? Mask ventilation not adequate. Consider attempt of surgical consider attempt of supraglottic airway. Succeed, then non-emergency airway. If it is not possible to ventilate with supraglottic airway, we should announce that we cannot intubate, we cannot ventilate, and we should follow the emergency pathway, call for help, and ask the most experienced person to help you managing the situation. We should limit the attempt and be aware of passage of time and call for help, as we said, for invasive access. Attempt alternative intubation approach as you are preparing for emergency invasive airway. If you success, this is our goal. Fail, then you go to emergency invasive airway. Here, if the mask ventilation is adequate, the non-emergency pathway, ventilation adequate, intubation unsuccessful, we can limit the attempt and consider awakening the patient. Consider alternative intubation approach, invasive access, or feasibility of other option. This is the same as we mentioned before. And this is the two algorithms integrated together. Intubation devices. We have a lot of devices in our hospital and in the practice. We should know what device we are used and be aware of other devices that's available. For example, in our ICU, the glidoscopes have angled blade, rigid blade, angled, and there is a lot of other options here. Also, there is channeled and non-channeled. We can pass the tube through the glidoscope. The literature is insufficient to evaluate which device are most effective when attempted first after failed intubation, or evaluate the most effective order of device to be used for attempted intubation of an anticipated difficult airway. Is there a difference between levering laryngoscope? This part of the laryngoscope, you can press this handle and elevate the epiglottis to facilitate the intubation. Compared to the normal standard intubation, there is no difference, but here less time and less maneuver required. Video laryngoscope, for sure, better than conventional glidoscope. Higher successful intubation, higher frequency of first attempt of intubation, fewer maneuver required. Channel guided video laryngoscope versus non-channel guided, equal, no difference. Hyperangulated video laryngoscope versus non-angulated video laryngoscope, CMAC, for example, it's available, I think, in OR. And glidoscope is our main video laryngoscope. There is no difference. Supraglottic airway, first generation and second generation. The second generation have the 3 or 4 more features. It reduces the risk of aspiration, more seal. We can ventilate with higher pressure. And there is a part here to protect against occlusion. Lighted or optic stylet versus blind intubation. The lighted stylet is better in successful intubation and less intubation time. Combination technique, direct video laryngoscopy combined with either optical, video stylet, flexible intubation scope, airway exchange catheter, retrograde placed guide wire, supraglottic airway placement, supraglottic airway combined with either optical or video stylet or flexible intubation scope. This is the retrograde intubation. You advance the guide wire from here, and through the over the guide wire, you introduce a Cook catheter or a tube exchanger, And after that, the tube over the tube exchanger, and you remove the guide wire from. Take home message, know your limits and call for help when needed. When appropriate, refer to the algorithm. If difficulty is encountered with individual technique, combination technique may be performed. Be aware and familiar of your working place airway management facilities. During extubation of difficult airway patient, consider short-term use of airway exchange catheter or supraglottic airway that can serve as a guide for expected re-intubation. This is another take-home message. This is the stylet of the glidoscope. If you bend it, somebody else in the night shift will have difficult time intubating patient. He see the vocal cord and he cannot intubate because somebody have angulated this hard stylet. If it is new, don't bend it. The other one, we can use it for that.